Thank you so much for allowing me to do this talk with Lori. We're very excited about it, so we decided to make this a dance. So I'll kind of introduce how this dance is going to work. But the thing for me, talking about contractures, it's a little emotional, so I'll try to keep it calm on many fronts. But my first boss, Eric Hoffman, told me when I wanted to study this that, it's just not very sexy. So either one, I'm really hard-headed, or two, I just here.
Yes.
But
I hear you loud and clear.
But the other one of the objectives, not on the learning objectives, is so we're hoping to bring sexy back, and so maybe not quite the way that whatever his name is, Justin Timberlake.
Yeah.
Thank you, does, but we'll do our best. So here are our objectives. We're going to look at contracture development in DMD and SMA, taking into consideration the disease process. What does it mean? What does it look like? How is it different in DMD versus SMA? And then, of course, we can't talk about contractures without talking about function and biomechanics. How does that impact function? And how do we, as clinicians, make decisions on care recommendations? We'll look at some of the practice approaches that have been published, as well as clinical sensibility. Because at the end of the day, the theme that you guys have been hearing is, does literature support it? We don't have anything. So how do we use our clinical knowledge and our understanding of the disease process to really make a decision that really fits our patients? Now, I want to introduce how this is going to flow. As you can see, I am in red today, and then Lori is in blue, and red and blue makes purple, right. And so whenever it applies to both, we try to keep the colors purple. If it's red, it's Duchenne, and I represent Duchenne, and then SMA will be blue. So let's first start with muscle physiology. We thought we'll start kind of 30,000-foot view, right? When we look at SMA as a motor neuron disease, while you look at Duchenne as a dystrophinopathy under kind of the myopathy umbrella. I'm not going to go into details of this because Tanya did a wonderful job explaining muscle physiology, but when you're looking at contractures, we really want to concentrate on the tendon and the muscle fibers, and that's really what is applicable in Duchenne. You go into SMA, it impacts motor neuron and its innervation into the specific muscle fiber. But in regards to contractures, we really want to talk about what are contractures and where is it happening. In the animal literature, as you can see up in, I'm not sure where to point, you can't see anything. You can see that contractures happen first at the tendon level. So the tendon is shortened first before the muscle itself. And then when we talk about contractures also, there's tightness that occurs. And that tends to happen at this extracellular matrix where there's increased collagen content that really is going to impact force generation. So you can already, knowing the disease process of SMA and Duchenne, you can imagine that this may be impactful for Duchenne because of the dystrophinopathy piece of it. A really great article done by Rebecca Wilcox at University of Florida looked at contractures and MRI. One of the first questions I had was, I feel like every time I have a question, there should be an obvious, of course, there's an answer to it. I asked Glenn Walters, can we measure tendon with MRI? And he's like, yeah, well, no. In this study they've published, though, they didn't quite look at the tendons, but they did look at fat infiltration and see if it predicted contracture development. And it moderately predicted it, but really the take-home message here is that there is something beyond just fatty infiltration and fibrosis that is contributing to muscle, tendon, or joint contractures. And it's not necessarily, the other question we have as PTs is it the muscle imbalance? Too strong of an agonist or antagonist that's causing those contractures? And in this study, they didn't find that. When we look at contractures, there's ways to look at how a tendon or a muscle may be lengthened. One is by increasing sarcomeres. The other, as many of you or who are therapists know, kind of a stretch reflex. Is there a relaxation of the stretch reflex that may result in patients improving tolerance? Those of you in industry, I know that your frustration with how do you quantify, how do you measure range of motion. We always use in trials min, mod, or max. Why? Because of these components here that causes that variability where we're tighter some days and not as tight on other days. So then how do we measure it? So I'm going to talk a little bit about basically biomechanical properties of muscle and how it has been measured. It could be ultrasound, where you can estimate tissue stiffness. the myotonometer, which measures muscle tone. You don't hear about that a lot, but I think, what we've discussed today, that may be worthwhile measuring. And there are a study or so using that. Electroimpedance myography, looking at, the stretch, the passive stretch, as well as MRI and MRS. And then clinically, Lori will talk about
goniometry, which I think any PT in the room are very familiar with. There's also motion analysis, and then this concept of joint end feels. So we thought it might be helpful to spend a little time talking about end feels. There's typical end feels, which are hard, firm, or soft, or hard, soft, or firm. And then there are atypical end feels. So a bony end feel where there's a restriction before a typical end of range of motion is expected. There are also muscle spasm type end feels, which is not to say spastic muscle per se, but more of this response with guarding and rebound. There are empty end feels, springy block end feels, leathery and boggy or soft. And the atypical end feels we will see most with our populations are the bony or springy block ones. And we feel like it's important to learn the difference in these end feels so the clinicians are really able to make a distinction between a muscle that is tight and a joint that is contracted. So in that regard, we really want to make sure that the words we're speaking about on this topic are on the same page. So when we talk about contracture, we're talking about a fixed tightening and a bony end feel that's related to a joint. When we talk about tightness, we're speaking to a muscle that is flexible and a more springy end feel. And then this idea of how flexible a person is and how that is really referring to the degree of available muscle extensibility.
So now I'll talk about the DMD physiology. As mentioned before, with Duchenne, without the dystrophin protein, it doesn't have a stable sarcolemma that attaches to the extracellular matrix, resulting in this membrane fragility. And with this, you have increased fibrosis and fatty tissue that really increases the passive resistance. So there's a lot of tightness within the muscle fibers itself. And there has been studies that show that this non-contractility of the muscle is correlated with strength and function in Duchenne. And then, of course, we know that contractures do develop alongside muscle weakness. Again, that's always the questions. Are the boys going up on their toes because their muscles are weak, or is it because it's just part of the disease? And so we'll talk about that in a little bit further, but when we get to the mechanics stage.
And then when we look at what's going on beneath the surface with SMA, we want to first remember that sarcomeres are where the contractions and the force and the movement is produced. They consist of actin and myosin, and the actin is bisected by the Z-disc. The Z-disc really define the sarcomeres and link them all together. And SMN we see is localized in the Z-disc and is really responsible for maintaining its integrity. So without the filament structures are really unstable, the force between them is impaired, and the signals communicated between the nucleus are disrupted. In SMA, then, the SMN levels are reduced. The atrophic and hypertrophic myofibers coexist, and then the hypertrophic myofibers are really the primary targets of deficiency. We see the myofibrils reduce in size. We also see, and we've talked about already this morning, the impairments occurring at the level of the neuromuscular junction. And I think we're all pretty familiar with the motor neuron degeneration seen in this condition. But it's helpful to keep in mind and to have in our heads, and we look at what is the result. And what results is really this classical pattern of muscle weakness with a muscle that is small, weak, and immobile. So when we bring these two diseases together, we find this symmetrical proximal weakness drives this immobility, which then further drives the development of contractures as an individual loses the ability to move through the entire range of a joint. For DMD, this is driven by the fatty muscle infiltration, and for SMA, this is driven by degeneration of motor neurons. So we've got two different disease processes with very similar outcomes as far as it pertains to joint contractures.
Okay, great. So now we get to talk a little bit about biomechanics, and this is more to, not towards the therapists of the room, because we think about this all the time because we like to judge people on how they move. But when we do, what we're thinking about is muscle length, skeletal alignment, that really, how does that play into muscle function and activity? We heard from Frank and Matt Hank and Matt just earlier, that this really is impactful in breathing and scoliosis, et cetera. The same is obviously true in movement. And so when we're thinking about this, we really think, what's leading what? And so
this idea of, is it the chicken or the egg, and is it form or is it function? So I think as an individual chooses a functional position and then succumbs to the form of this position, or is it form really driving how the person functions? So I think when we think back to scoliosis and we look at all the different individuals on this slide at each functional level, we can see how a curve might be developing at those levels and how it might further drive a person to use that position of comfort and assume that position as their now typical form.
So then we go into, I'm going to talk about the Synergy Natural History Study because this is part of the emotional component of contractures that I have with contractures. So whenever I was thinking about a PhD project, what I wanted to know was what drove what. And so since I worked in a genetics lab, they thought, is there a genetic component to contracture development in Duchenne? And we did a genome-wide association study. And what was really interesting, I'll just keep this brief, is that you could see the phenotype with ankle dorsiflexions AD, knee extension is KE, that these were significant. We did not expect this because our numbers are so small to have any associations. But what I thought was really interesting was that at the time, it was before vamorolone is now vamorolone, we looked a lot look at inflammation, TGF-beta, regulation, and you could see how the similarities that the hits that we found in the single nucleotide polymorphisms associated with Duchenne. Basically, the take-home message that in Duchenne, there may be a genetic component to contracture development, and it may not be entirely function or muscle imbalances that led to that. Okay, so when we talk about function, even how we describe it in Duchenne versus SMA is a little bit different. In Duchenne, we describe it in stages, ambulatory and non-ambulatory, but we have 1, 2, and 3, pre-symptomatic, early, middle ambulatory, and then in the 4 and 5, we have early non-ambulatory and late ambulatory. So that it's pretty well described as in staging of the diseases. The other thing we know about Duchenne is there is the progression rates may vary, but it's very sequential in the loss of ambulation. So first, what you'll see is a Gower sign with the difficulty trying to get up from the floor, followed by difficulty stair climbing, and then standing up from the chair, and the loss of independent walking. And many of you who do practice in Duchenne, we do use something like the 10-meter walk test, stair climb, as a predictive measure on when somebody may lose this skill, because we know of the very clear sequential loss of these functional milestones. When we looked at range of motion, or I'll focus on dorsiflexion, we wondered, there's steroids that are used in Duchenne. Do steroids really impact contractures? What we found was initially it does. So you could see the non-steroid users are in blue, and the red is in red, or not red. The steroid users are in red, and you can see there's a clear difference there. However, when we looked at a 12-month change, it really didn't matter if you're on steroids or not. The progression itself didn't really seem to change. When we looked at what measures really significantly predicted time function tests, we found that the strength of the knee extensors, ankle range of motion, as well as age and steroid use were the significant factors that played in how fast a person could walk, climb the stairs, or get up off of the floor. The other thing we wanted to see is what we found when we were looking at the data, the number 10 seemed to stand out a lot in ankle dorsiflexion, so we divided the groups up, greater than 10 degrees and less than 10 degrees. And what we found was that those two dichotomous numbers really played a significant factor on how fast a person's able to do the time function test. And when you think about it mechanically speaking in the plumb line, without all these contractures, you have the center of gravity going through the greater trochanter. But then with Duchenne, you see the shift of that center of gravity causing an increase in load or requirement from the glutes to work, the quads, and the gastrocs. And so this, of course, decreases the efficiency of gait. So I thought, that makes sense. So are there biomechanical data that shows this? So in a study, they looked at normal gait. They found that at 10 degrees of ankle dorsiflexion, there are changes in demand of the muscle for anyone. You don't have to have Duchenne or any other disease. And so you can imagine with Duchenne, having that 10 degrees, it's detrimental to maintaining ambulation. And one of the things then, the Wilcox paper that somehow didn't show up, they found 20 degrees. None of the boys who had 20 degrees of ankle plantar flexion contractures were ambulatory. So there's that critical value point between 10 and 20.
When we look further at the comparisons of gait for both diagnoses and how this form might further drive function, we want to consider things like that presence of hyperlordosis and that symmetrical muscle weakness, though I would hesitate to say the muscle weakness is truly symmetrical. I think we always see one side that is usually more affected than another, and that could be driven by things like scoliosis or preferred use. And then when we look at the levels of muscle involvement, this is thought to be comparable throughout the ambulatory phases in both. But then there are also some distinctions between the two diagnoses, like that could influence form as well, like the rotational components, the strength of the hip extensors and quads versus the strength of the hip flexors, and the particular kinematics at the stance and swing phases. When we look to the SMA functional levels for SMA, we consider the function of the person and think about where contractures might develop based off of the functions that are available to the individual. And we look at patterns of movement and weakness, and we consider then what type of structures are going to be at risk. For example, in walkers, we see that the decreased strength in the hip and knee muscles really leads to a compensatory use of the plantar flexors, hip rotators, and abductors, where at some point the function becomes compensated because of that particular form. For SMA, the typical untreated natural history has looked like progressive muscle weakness and loss of function in all types, though with differing rates of progression, and typically presenting itself first in the lower limbs more than the upper. We also see certain age groups that have historically had distinct times of regression. And while this natural history is becoming quickly outdated, the information is really still important to keep in mind when looking to our treated population and in finding that balance between what was expected and how the new natural history is modifying that expectation. I think the previous natural history is also really important for helping make predictions, goals, and then different plans of care. Other things that are going to impact how a person progresses through this natural history are how the standard of care is applied, the person's age, where they were at baseline, the progression and duration of the disease, the presence of contractures, scoliosis, and then muscle imbalance. So we're spending most of our time here on contractures, but we can't really talk about biomechanics and joints in SMA without giving at least a small moment to the presence of hypermobility. And I think this is an area that's really starting to gain some interest. We usually see hypermobility present at the elbows and the knees. And just as we would in other populations that demonstrate hypermobility, we want to be mindful of how this is going to affect a joint long term. We should focus on joint protection and mid-range strengthening and the potential impact of how a hypermobile joint is going to affect the other joints around it. And so now we'll go back into more this joint contracture and the impact of function specifically. And we will look at how contractures take place and how they occur. We generally see that the knee is affected first, followed by the hip and then the ankle. And there are some distinct patterns between the functional levels as well. So while it is expected that a majority of individuals are going to develop a contracture at some point, those with type 2 are more likely to be limited into knee extension, and then those with type 3 are more likely to be limited into ankle dorsiflexion. Range of motion is also thought to have a threshold for performance on the Hammersmith, and we see contractures emerging in those different age groups, but by age 11, 100% of individuals with type 2 have had some degree of contracture. We see that due to hip flexion contractures, there are resulting limitations in rolling and the ability to achieve skills in prone. With ankle plantar flexion contractures, there are challenges to achieve standing even when strength and postural control are present. And we find that even when a person is working to improve strength, the improvements to function are limited because the contractures are really overriding those potential strength gains. We also need to acknowledge the contracture developments that are going on in the upper extremity. We see these two progress over age and first appear in the shoulder, then the elbow and the wrist, with the most marked distinction occurring primarily at the elbow. There are also some contractures in the upper extremity that have correlations with pain and discomfort. And when we speak to this adolescent study in a few slides, they will look at the impact of those end-stage contractures of the wrist and hand and how those are really concerning for a person's function and independence. There are a few studies that have looked at contracture development and how this has changed with disease-modifying therapy. This particular study looked at 40 patients between the ages of 4 months to 20 years that all had some form of pharmacological treatment and all received PT. They were examined twice over a 5-month period with an average of 5 months from the start of treatment to their first PT exam. And the study looked at the CHOP and the Hammersmith, as well as upper and lower limb ranges of motion, which included shoulder flexion and abduction, elbow flexion, forearm pronation, supination, hip flexion, knee flexion, and ankle dorsiflexion, hip extension, and cervical rotation, so the whole body. They also looked at 4 tests of early detection for musculoskeletal changes, which included the supine angle of trunk test, measuring the angle of upper and lower limb trunk rotation, and then pelvic obliquity. And what they found was improvements in all motor scores, favorable changes to all range of motion for all parameters throughout, with the greatest change in the bilateral hip flexion, knee flexion, and cervical spine rotation. They saw no differences from the norms in ankle dorsiflexion, shoulder flexion and abduction, elbow flexion, and forearm pronation and supination. And finally, for those that received the CHOP and TEND, better scores were correlated with left hip flexion and hip extension. And for those that received the Hammersmith, better scores were correlated with greater hip flexion and extension motion. So I think what this study does for us is it helps us to keep the hip in mind and to consider that with goals and treatment, and then to consider how contractures are really going to reduce the changes for improvements in motor skills. Another study looked at 27 children ages 6 months to 15 years and similarly assessed the CHOP and the Hammersmith, looked at a range of motion measures of neck rotation, shoulder joint flexion, elbow extension, and hip joint flexion with knee extension, so the popliteal angle. And this also measured trunk and strength via dynamometer. This study found that the CHOP scores were most affected by shoulder flexion limits and correlated trunk deformation with decreased function. They also found that neck range of motion decreased with chest deformity. The Hammersmith were most correlated with head rotation and with some muscle strength, and there were more significant relationships for range of motion in the neck and the limbs. They found more typically positive relationships seen in the CHOP group, in which the values of force measurements were lower than those in the Hammersmith. A few additional studies included a systematic review, which found type 2 continuing to have more range of motion limitations than type 3. And then there was this look at how contractures impacted the day-to-day life and participation in adolescence. And I found this one really interesting because it was done in an interview format, so it was sort of this, what do contractures really mean for the individuals experiencing them? And they found that their weakness was really more of a concern than their contractures were. They felt that they had kind of adapted to the contractures over time. And if they were being recommended to do some management for the contractures, they were more likely to participate if they found the goals meaningful and realistic, and if they felt like they were really going to help them to change. There was a large motivation to do contracture management if it was going to enable them to wear shoes. And there was a big concern, as I mentioned before, about this loss of hand function with those end-stage contractures. And that was really the biggest worry as compared to any of the other contractures that they were experiencing. So I think this starts to bring us into this consideration of the lifespan. And we know that even with disease-modifying therapies, there really is this ongoing loss of function, and the management of musculoskeletal health is very important at all ages and stages. We also spoke to how a person's motivation to participate in contracture management might change from one time of their life to another. So just because a person has failed night splints at one time in their life doesn't mean they're always going to fail that particular management. And we need to keep in mind a person's readiness, the concepts of readiness, the timing, the awareness for all elements that are affecting an individual and the type of management that might be the most appropriate. And I think we should also consider how contractures are impacting a person's quality of life. So this can be some component of our education as we work to help and encourage patients to participate in it. And I think it ultimately should be a component of our considerations for risks, benefits, and ultimately the impact. So now we're going to move more into the different types of management that are recommended for contractures. There are published standards of care for both of our diagnoses. They're based on expert opinion, and they were both published and updated in 2018. Both of them include the patient at the middle, and both of them demonstrate a lot of different multidisciplinary providers. And the main recommendations on both standards of care for contracture management are for bracing, stretching and positioning, standing, and serial casting. And then there's a few nuances based off of each diagnosis. For example, for SMA, there's a recommendation for thoracic and cervical bracing for lower functional levels. And then the recommendation most of us are familiar with the not recommendation for day AFOs for ambulatory individuals with DMD. The SMA standard of care is a little more specific for frequency and duration and highlights this minimal versus optimal level. I really like this to have an answer for patients that are wondering exactly how much of this do I need to do to make any sort of difference. And I think it's nice to be able to say that from a what's best and what's realistic perspective. And I think that can help give us some good answers for exercise prescription. The DMD standard of care does not give us much detail in that and really just has a vague recommendation of 4 to 6 times a week for each of the different management strategies. So we're going to speak to each of those a little bit more specifically and the research behind them. But as we move into that, we want to be mindful of the specific structures that are at risk for contracture development. And there's, again, a lot of overlaps between diagnoses for both of these. We see the gastrocs, hamstrings, IT bands, hip flexors, forearm pronators, wrist and hip finger flexors and extensors and lumbricals are all affected in both diagnoses. And then we see the SMA looks a little bit more into cervical rotators and face and jaw muscles. And DMD has a little bit more attention to the posterior tib and the plantar fascia.
Great. So now we'll talk a little bit about contracture management. And so when we do, we kind of categorize it in 2 buckets. And this came along with some of the work I ended up doing when I was working in wearable robotics, trying to explain to engineers what we do. And so we looked at short duration stretching, as in stretching as a patient's able to do it actively or a parent or caregiver is doing it passively. The long duration stretch we categorize as using braces, wheelchair support, standing frames, or positioning devices. So what does the data tell us? I'm guessing you guys can guess. But there's a lot of resources out there for stretching, safe ways to stretch, including PPMD's range of motion guidelines. And this all came out because we really had a hard time with the discrepancy in what clinicians were telling parents and families that they need to have stretching because it's going to prevent a contracture, leading to a lot of guilt that is felt by parents because they couldn't stretch enough. Right? And so the short answer is like, it's not going to prevent anything, but there may be other benefits. And so stretching, we should not throw the baby out with the bathwater, but it does help. And so there's websites that is on PPMD as well as Cure Duchenne that could really, you can guide your parents and families to help that. So this one was cool. There was a Cochrane review done by Rose et al. In 2010. This does say a lot. When in the Cochrane review, with the strict criteria they had, they threw out all the Duchenne data because the inferior research design. And so the other thing they looked at was surgery. So if you're going to do conservative versus like something much more invasive like surgery, did it help? And no, it didn't help. So we go to a systematic review that's done in 2016, looking at 16 more studies, and what they found is pretty much the same. Nothing says, yes, do stretching, or no, don't do stretching. However, I want you to keep in mind that when we're talking about bracing and we're talking about standing programs, there are things beyond just range of motion that may benefit from some of these interventions, such as improvements in gait or bone density that will be part of the next session. And also, improving stretch tolerance may make them feel better. Touch therapy also is helpful, so keep that in mind. When we looked at the synergy data from the really old NIFTY study, we just looked at patients report or families reporting, have you used braces, have you not used braces? Have you used them somewhat or daily? And then we found that there's a significant difference between those that report using it daily compared to those that on occasion uses it. That's very nondescript, but that gives a general idea. The other thing I want to present is just because we don't know that much about stretching and contracture management, PPMD did host a meeting in which there was a survey that came out of 66 neuromuscular clinicians saying, what is your practice? And 95% of them recommend stretching as a home exercise program. But the barriers that were reported were time. This is limited by, families really buying into it or forgetting to do stretches, as well as behavior issues. In the survey, the recommendations for muscles that should be stretched were the gastrocs, hamstrings, and hip flexors. And as they move along the trajectory of disease, in the transitional ambulatory, they added the IT bands, as you guys can imagine, with that abducted posture. There's more tightness in the IT bands. And then in non-ambulatory, they added elbow flexors, wrist flexors, and finger flexors. And the MRI data coming out of University of Florida, one of the first upper limb muscles that are weak would be the ones to be able to get you into supination. The general consensus is about 30 to 60 seconds to hold the stretch, and it should be determined by the patient's infield.
And when we look at stretching in SMA, we have very similar limited evidence to its support, yet it's continued to be recommended in the standard of care, and we find that is most effective when held for a more prolonged duration. So we'll go now into more of those longer duration stretches and strategies, which include orthotics and bracing. For bracing, what we know is most effective if it is related to a particular goal, and that the use of bracing may help delay contracture development and improve motor function. At Lurie, we do a lot of work with KAFOs to enable a person to do standing for those that have type 2, which is really advantageous from a standing and contracture standpoint, but also can be a strategy for ambulation and fitness. So here are some examples of bracing shown here, and I think really bring to mind how bracing might help improve function and how function in a good alignment could potentially drive an improved form.
Great. So when we looked at a retrospective review, I'm focusing on Duchenne because this retrospective primarily had boys with Duchenne. They looked at orthotic use. One of the things I found interesting was that there was increased range of motion in the orthotic group. However, it was really interesting, there was a significant decline also in those who had that increased range of motion. So as you think about biomechanics, what's happening here? Maybe the strength, the impacts of strength on the elongated muscle length and the ability for that force production may result in maybe that decrease in time function test. I just thought that kind of was counterintuitive in what we're doing, so thought I'd point that out for your brains to work a little bit. In the survey that we looked at in Duchenne, orthotics or night splints were recommended. In ambulatory and non-ambulatory, the primary difference was that DAFOs or hinged AFOs were recommended for those who are ambulatory, while more of a solid AFO for those who are non-ambulatory. One thing I just thought was really interesting when I was working on the bracing robotics project, what we looked at was midfoot rotation. So I always found it really annoying that there wasn't that control in bracing. So I wanted to make my dreams come true working with this group. And what we found was that those who lacked at least mid-range midfoot inversion and eversion, they had too much in a supinated position. Then whenever you put the bracing and then you increase that force to stretch, you're actually increasing that plantar flexion contracture. So as clinicians, you're recommending this or not, make sure you do check midfoot range before you fully recommend AFOs for patients with contractures there. Then in regards to wear time, there's just some strategies that help, compliance, and that's alternating the feet, wearing it while they're watching TV, taking it off on weekends, and if they're in a wheelchair, have them wear while they're sitting in the wheelchair. So when we look at standards, there's one study done by Elise Townsend in 2016 in which she looked at standing in a standing frame. And the biggest point I want to make here was the target was 60 minutes, but the actual use was 3.5 and 7. So that feels familiar to all of us, right? And so you won't be surprised that the study did not show any differences or improvements because it's not really probably getting the correct dose. Very similar to what we talked about with TLSOs. When we looked at the surveys, however, standing frames were recommended by 77% of PTs, but there are other interventions also recommended for the management of musculoskeletal health, and one being massage. And I like to bring this study out because I really like when people think outside the box. It's something that parents ask us. So Kate Carroll's group in Australia did a nice job looking at 10-minute massage, and did that help? They used the goniometer, the myotonomometer, I have a hard time saying that, gait, and ultrasound. And what they found was it was not only safe, but it decreased the gastroc stiffness and increased muscle length and stiffness based on the ultrasound findings.
Standing in SMA, we know, is safe, tolerable, beneficial, and great for all children of each functional level, even if they are more fragile. They're also receiving a lot of different benefits other than contracture management, GI function, pulmonary health, and this opportunity for cognitive and social engagement. So this shows some examples of kids standing and a lot of nice standing opportunities. Some of them are more supported, some are more dynamic, and I think demonstrates that while this may be being used for contracture management is not operating in a silo. There's a lot of different benefits that an individual is getting when they are performing standing, and that's a really important component to include in all plans of care.
Okay, real quick on serial casting. There are two studies, one for Duchenne, one being a retrospective review by Alan Glanzman, and what he did find was there is a gain of about 12 degrees for both legs, and about an average of a 2.5 degree improvement for each of the casts. However, it did not impact time function tests, so we're getting a little bit of conflicting things. And then Marion Main also did a study that looked at tendon lengthening as well as the use of orthotics, and take-home message, there's no significant difference between any of the groups, and so hence why a lot of times tendon lengthenings are also not recommended in Duchenne. And also in the survey, we looked at ambulatory versus non-ambulatory, and it was really rarely recommended in Duchenne, and definitely not recommended in those who are non-ambulatory.
And in serial casting in SMA, I'm happy to say this was submitted Wednesday to the Journal of Neuromuscular Diseases, but this is our work on a modified Delphi survey that was conducted over the past 3 years. It involved an expert panel and then a 2-round survey looking at 3 subdomains to really consider for serial casting with this population: whether the person is clinically appropriate for the strategy, different considerations to be included in a program, and then program adherence and feasibility to look at. Ultimately, 18 PTs completed round 1. These therapists had a variety of experience, had worked with different phenotypes, were primarily in the US with a strong Midwest representation, but did include some individuals in Europe and Asia as well. The first round had generally good consensus, with program adherence and feasibility having the most areas to reconsider. On the second round, 15 PTs completed the survey, and a greater than or equal to 95% consensus was found on all the new items. And at the end, there was a consensus which was defined ultimately as greater than or equal to 75% agreement on 296 items. So the guideline that was produced has a heavy emphasis on the use of casting to improve range for the performance of a particular functional gain. So that might mean improved gait kinematics, pain control, or the ability to tolerate a standing frame. The guidelines also recommend a very individualized approach for setting goals, and they highlight some specific alignment assessment and ranges to be considered, and it outlines specific expectations for consideration after the program is completed as well. We're hopeful that with this work, there's going to be a more standardized approach to SMA so that the efficacy of casting can really more clearly be demonstrated. So we've given a lot of different strategies for contracture management. And as we wrap up and review, we want to work to manage contractures in the interest of improving function, decrease muscle tightness, and create a positive effect on muscle force production. We hope to manage orthopedic deformity and the awareness that this changes the biomechanics of movement. And we also hope to decrease pain and improve tissue extensibility. We are aware that there's really no one-size-fits-all for contracture management. And as might be highlighted with the serial casting, even if we know something is effective, an important part of the program is to know whether the person is right for that particular type of management. And it's going to be very much based on the individual and a family. But I think being aware of some of the common perceptions is helpful. For example, going back to the adolescent study that we talked about, and I believe we spoke to this in a case or two yesterday and this morning as well, there's certain perceptions around different contracture management that are necessary to know about. And one is that some people see orthoses and standards as unnecessary and burdensome. That doesn't mean we shouldn't promote their use, but I think it's good to know that that concept is out there. As Tina mentioned, there are some thoughts that going to PT in itself is good, specifically the hands-on component of that. And I think that's nice to consider when a person or a patient is wondering, should I go back to PT? Is this a necessary thing for me at this time? So in managing contractures, we should always work to share the goals and decision making. We need to be mindful of the lifespan care, and we should monitor and revisit those goals regularly. We should also work to reduce contractures through postural management, encouraging early stretching and splinting, and be aware and considerate of the role that static positioning plays early on in a person's life and throughout the lifespan. We should also be aware that the development of contractures is unfortunately inevitable. And once advanced, there is really little response to conservative interventions. So we've demonstrated that there's really a lack of evidence supporting stretching and orthotics and a lack of consensus on the benefits of both. But we've also shown that there is sort of a necessary paradigm shift to occur, that contracture management is still important, not to necessarily prevent contractures, but to promote function, improve quality of movement, and create this opportunity for better muscle balance.
Great. And so just to close us out, some of the really takeaways are words matter so that you have management of expectations. So I mentioned about the guilt part of Duchenne. The other is stretching. It impacts something beyond range of motion, maybe increasing blood flow into the muscles that may improve tightness, that may improve quality of movement. And of course, as Lori said, one size doesn't fit all. There are a lot of gaps here, and every data point counts. So if you have cases that you're using that or you're seeing that's unique, do publish on it, because you can see what little data is out there. We as a group have to work together to address some of these gaps, and that is primarily to understand how range of motion and contracture impacts function, and then how we measure it. Goniometry just may not be the target, and if we're measuring the wrong thing, are we really being able to show if something is effective? And the other thing is a little bit more focus on the upper limb would be helpful. There's very minimal data that's out there for contractures, and even less than that for range of motion. But with that, we're going to end with a moment of Zen. There's some DVDs out there, embarrassingly so, that I made about 20 years ago. You can have it as give it to your parents and your families. There's active and passive stretching that's being done with these group of boys. Hey, Pablo, do you want to share that song you wrote for us?
Yeah.
All right, let's get going.
I'm a part of the Stretch Out crew.
I'm a part of the Stretch Out crew.
He's my friend and so are you.
She's my friend and so are you.
Stretch on the left side, stretch on the right.
Stretch on the left side, stretch on the right.
Helps me not to get too tight.
Helps me not to get too tight.
Stretch out.
Stretch out.
From DC, so they were the stars of that video.
Contractures. Both the Duchenne's and SMA I've found to be extremely sensitive in terms of pain, post-op pain, with management. Is there anything that you guys have found? Obviously, one's a primarily motor neuron disease, one's a muscle disease, but those kids have more pain after simple tendon lengthenings than any other children that I've seen, and I don't have an explanation for it.
I think I agree with you. From a Duchenne perspective, we don't have a ton of boys who do tendon lengthenings, but the ones that end up doing it is because they're pretty strong already, and those who are already strong, they're mobile, and so then are a little more mobile, so they can get out of bed quicker, and maybe that they also have less pain compared to the boys who are on the transitional phase where, a tendon lengthening sometimes just entirely takes them off their feet. I don't know if it's related to lack of movement that increases pain because the surgery results in them not moving as much. I don't know.
I think in SMA I've seen there's kids who just refuse to let me touch their feet. There's just a sort of baseline hypersensitivity, and perhaps that's from not being on their feet and getting that sensory input from a majority of their lifespan. So
Like
I think
almost
that
like
that-
needing like sensory reintegration. You know, those of you who do outpatient doing proprioceptive and sensory reintegration may be helpful before getting them on their feet and trying to weight bear and things.
And I've applied some like desensitization strategies with first tolerating massage, then tolerating different textures and that, like you would in a pain population. So.
Like using modalities possibly. And I mean, that hasn't been looked at or standardized, but I think it's worth thinking through.
Great talk. I really enjoyed it. I guess in thinking about how stretching might improve blood flow and massage might help as well, I'm wondering if people have looked at biofeedback devices like haptic, like stimulation, and whether local stimulation might help to prevent contracture development.
I'm not aware of that, but I mean, I think it makes a lot of sense. But I think maybe some of it's that we don't know how to also measure that increased blood flow. I'd be curious, in even looking at things like NIRS, if you did do a massage, does it increase, oxygen uptake, those kinds of things. I think Kate Carroll's study on massage is really key for us in regards to the concept of increasing blood flow that improves the sensation of feeling better, even.
Early studies in looking at spasticity and
Yeah.
stimulation, and I know mechanisms are very different for
Yeah.
Duchenne and SMA versus like upper motor neuron diseases, but I'm wondering if there's like a common treatment or solution.
Not that I know,
I was trying to
but
think about
I'm sure.
Yeah.
I'm sure somebody maybe online smarter than I am and know this answer.
Okay, so I will take a few. There's a lot of questions from the online audience, but I promise that Tina and Crystal will get back to you. So I will just take two. Do you recommend the use of sleep positioning systems for prevention and or correction?
That's perfect for you. I'm sorry, could you repeat the question? I'm back.
Do you recommend the use of sleep positioning systems for prevention and or correction of contractures?
The recommendation for positioning.
Is
During
there
sleep.
any system during sleep? Yeah.
Not specifically for sleep that I'm aware of, but we do a lot of promotion of prone positioning throughout the day and really all different functional levels.
Yeah, so group number 5, I was, you mentioned the sleep device, right? Like one of you mentioned the sleep device. Could you speak about that maybe? That'll.
Yeah, so at CCS, we're starting to see, or we've had a few vendors show us various sleep positioning devices. One of them is called the Dreama, and it is a slatted system that provides extra supports that you can kind of modify based on what kind of contractures or positioning you want the child to be in. And so it seems to help alleviate some of the kiddos that have like pressure issues or things like that. So it's something that we started to explore, and Medi-Cal is starting to approve. So it'd be interesting to see if that, for some of our kids who are non-ambulators, are spending more time in bed, if we can get them in better position for longer periods of time, maybe it can slow the progression of contractures. But I mean, I haven't read data on that quite yet, and since these are relatively new systems as far as I know. But maybe some other CCS therapists can speak to that.
Great, thanks. I just learned that yesterday from you.
Yeah, news to me.
A comment about pain and Duchenne's. I think prior to surgery, commonly Duchenne's will have a higher level of pain. We find that about half the kids in our clinic even have pain, irregardless of surgery or not surgery. And then in SMA mouse studies,
Can I ask you a question? Is it like just generalized, like hypersensitivity, or
Yes.
specific? Okay.
generalized.
Yeah.
And then in SMA mouse models, they show noroceptive dorsal root ganglion hypersensitivity. So it might be there in SMA.
Stay on schedule. We're going to conclude this session. Thank you again